to our ANAwareness Week 2021 webinar series. I hope you've had an opportunity to join us before this, but if not, we're happy to have you today. Today's presentations run back to back as they did yesterday afternoon, so we'll handle it the same way. If you want to attend both presentations, you can just stay in the webinar or continue to watch Facebook. If you'd like to join with only one or the other, you can come and go as you please with the same link. We want to offer a huge thank you to these doctors and to the entire team at Mayo Clinic for a great slate of presentations. We've been overwhelmed with the amount of information shared already, and we still have so much more to come. Our first presentation today focuses on hearing rehabilitation, and we're excited to welcome Dr. Matthew Carlson and Dr. Nicholas Deep, both otolaryngologists at Mayo Clinic. Dr. Carlson is in Rochester, Minnesota, and Dr. Deep is in Phoenix, Arizona. Thank you both for being here. I'll have you introduce yourselves and tell us a little bit more about your work with acoustic neuroma patients in just a minute. First, I want to mention a couple things to our attendees and how things will run today. All of our attendees are muted, so if you're only able to listen, you're only able to listen. If you have questions, you can type those into the questions box if you're on the webinar. If you are on Facebook, you can type them into the comment section. There should be captions at the bottom of your screen. If you don't see them, go ahead and click the captions button in your toolbar to activate them. If you're in the webinar on Facebook, you may have to activate them in your settings if you don't see them. We are recording this presentation, and we will house it on the ANAwareness Week landing page in the presentation section. We'll also keep it on our Facebook page and add it to our video library on our website. There's lots of ways to get involved in Awareness Week. You can visit our website at www.anausa.org and click the slider on the home page, and that'll take you to the page where you'll find everything you want to know. Again, once we're done with this presentation, if you want to stay for the wait and scan session, just sit tight until the start time. In case other people want to join us, we'll wait until the start time, and we'll move right into that. And Dr. Carlson and Dr. Deep, welcome. Thank you for being here today. If you want to tell us a little bit about your work with vestibular schwannoma patients at Mayo Clinic, I'm going to stop sharing my screen.
All right, I'll bring up ours here too.
Okay, awesome. Thank you.
All right, my name is Matt Carlson. I'm, as Melissa said, I'm one of the otologists here. We have 3 otologists or ear surgeons and then 3 neurosurgeons that all have a special interest in vestibular schwannomas. I think every center kind of tends to specialize in certain areas of their practice, and certain areas might provide them with more fulfillment, et cetera. At Mayo Clinic, we have a particular interest in treating patients with vestibular schwannomas. One thing that I think is, I wouldn't say unique, there are a number of good centers that have a similar pattern, but I feel like we're relatively, as much as anybody could say something like this, unbiased and towards all three treatment modalities, in the sense that basically it's a third receive all those different treatment modalities ultimately during their journey with their tumor. And so, which I think is an important thing. Everybody tends to treat somebody with the tools they have, and if they don't have a particular tool or they're not used to treating a person a certain way, that might not be offered in the same way. And so in that way, I think that's something that we have a lot of pride in. We always see everybody together, a neurosurgeon and an otolaryngologist at the same time. We think you get the best care. It's something that Mayo Clinic has been built on, is that collaborative group care. And it's not just having you see me and then going down, the next day seeing the neurosurgeon. It's typically seeing us both together in the same room so that you get the same consistent message when we review your scans and talk with you to together arrive at what the best treatment option might be for you. Dr. Deep, I don't know if you want to.
Sure. Great to be here again. Thank you, Melissa, and to the ANA. I'm Nicholas Deep, neurooncologist in Phoenix, Arizona, part of the skull-based team here. Like Dr. Carlson mentioned, we work as a team with our neurosurgeon, our radiation oncologists, neurologists, and so I think that's one of the big strengths of how Mayo Clinic approaches vestibular schwannoma care. As Dr. Carlson mentioned, very unbiased and very collaboratively.
So today we're going to primarily, this talk, I think it's really important so we're talking about rehabilitation of hearing loss in patients with vestibular schwannomas. And it's really important on the first layer to separate patients with a unilateral, meaning one-sided tumor, compared to patients with NF2. Patients with neurofibromatosis type 2 most commonly have a tumor in both ears. And so the consequences of that with regard to hearing are significantly different, and your options to treat a person are significantly different. So 95% of this conversation is going to be surrounding what most of the people on the phone or on this conference call have, and that is specifically a one-sided tumor. Just as some background, we're in Mayo Clinic, southeastern Minnesota. It's actually a pretty small town of about 120 to 140,000 people. It's surrounded by cornfields, oddly enough. You know, a lot of the early towns and settlements in the mid 1800s settled around large waterways, whether it was a river or a large port town on the coast and things like that. And Mayo is pretty unique in that it's one of the few counties in Minnesota that doesn't have a lot of lakes. So land of 10,000 lakes, Olmsted County has very few. How Mayo Clinic arrived to be where it's at in Rochester in the kind of in prairie or farm country is that very early on, William Morrow Mayo came over from England, and he settled initially on the East Coast. He went to Indiana, then he went to St. Louis area, back to Indiana. Then he ended up coming up to Minnesota, and it was in the early 1860s, right as the Civil War was breaking out, that Abraham Lincoln identified William Morrow Mayo as a surgeon of good reputation and assigned him to be the examining surgeon or physician for draftees during that time. And in the southern part of Minnesota was the outpost, in Rochester was the outpost for people coming who were being drafted into the Civil War. So he was here during that time, and he developed even a good reputation in Rochester, and ended up just hanging a shingle here, and the rest is history. So that's how we ended up being in kind of a smaller town. You know, we always joke that you drive and it's pretty flat, and you see over the hill you see the large towers, the Mayo Clinic coming up. So it's a unique area, very clean, I think very safe and easy to navigate for people. We have a long-standing history of treating patients with vestibular schwannomas here. I'm a big history buff, both for just general medicine, but also things in otology. And I look back at our medical records, and the first person I could identify that underwent surgical removal of vestibular schwannoma was in 1907. We had the third gamma knife unit installed in the United States in 1990, and have treated almost 1,000 patients with gamma knife radiosurgery here. We have good collaboration between otolaryngology and neurosurgery. We see about 200 new patients with vestibular schwannoma each year. And of course, you add to that the patients who are still undergoing observation or maybe in their post-treatment surveillance. So we see a large number of people with this condition. This is one of the interesting operative notes from very early on. I think this is from the 1920s. It just shows how far we've come in our treatments. In this operative note, it basically, this is from the 1920s, the patient was held down and given ether, and they were operated on while they were still awake, and the surgeons were complaining that the patient was moving too much. So fortunately, we've come a long way, and you won't remember your surgery if you have surgery, and we have other very good treatment options as well. We've kind of gone through this, just some of the things that are unique or important parts of our practice. We also have a book. It's probably more than you want to read, but there's about 580 pages on the history, the diagnosis, the management, treatment of some of those associated complications and things like that, that I think is very evidence-based. It tries to summarize all the literature on any single aspect that you might be wanting to know about for vestibular schwannoma. So if you're interested, it's available on Amazon and other similar sites. So we'll talk about how hearing is tested and classified, just how common hearing loss is, how hearing loss is unique for patients with vestibular schwannomas. We'll talk about single-sided deafness, cause for hearing loss in patients with a unilateral vestibular schwannoma, use of conventional hearing aids, routing technologies, cochlear implantation, and very briefly, we'll talk about ABIs, because ABIs are very, very rarely used for somebody with a unilateral tumor. So what about hearing loss? A lot of times, if we look at hearing loss overall in the vestibular schwannoma population, most people end up with hearing loss in their affected ear to varying degrees through their journey, whether it was at time of diagnosis or after treatment. These are some quotes from Helen Keller, who is unique in the sense that she was blind and deaf. And when she prioritized the loss of both senses, she felt that hearing loss was even more of a significant burden than losing vision. And certainly, I think a lot of patients can attest to that. And so I think it magnifies the importance of finding ways to rehabilitate. Just broadly, when we talk about hearing loss, just give an overview of how it occurs. Something generates noise that creates ripples or sound waves moving through the air, much like ripples in a pond if you throw a rock in there, and those waves will hit the eardrum and vibrate the eardrum, and that vibration is transmitted down the three bones of hearing, the malleus, incus, and stapes, and that creates a fluid wave in the third bone of hearing. The stapes almost acts like a plunger. It moves in and out, and it creates a fluid wave in the cochlea, and that deflects hair cells in the cochlea. Hair cells in the cochlea move back and forth in the wave of water, almost like seaweed in the tide going in and out. And it's the deflection of those hair cells that creates an electrical current that goes to the brain that gives you the perception of sound. And so there's basically three types of hearing loss. You can have a mechanical blockage from something in the ear canal, problem with the eardrum, or problem with the bones of hearing. That's just from sound not getting there. And then you can have a nerve hearing loss that happens from the nerve endings themselves or the hair cells in the inner ear. And then more specifically with patients with vestibular schwannomas, the cochlear nerve itself is at risk, both from the tumor and also from treatments. I think everybody on this call has probably had an audiogram done of themselves. And for us, we see them every day and we take it for granted that they're actually pretty hard to interpret. If it's your first time looking at them, they can be extremely confusing. So if you look at an audiogram or a hearing test result, you'll get a box. And on the top of the box, so on the horizontal axis, so across this way, that's your frequency. So on the left side, it's very low pitch. On the right side, it'd be very high pitch sounds. And then moving from top to bottom, you're talking about things getting louder. And so for your left ear and your right ear, you can talk about the severity of hearing loss. This is what you might see on a hearing test. This would be normal hearing in the right ear. Red in circles usually indicate the right ear. And X's and blue typically by convention indicates your left ear. If it's above this line of 20 or 25, depending on what center you're at, we call that normal hearing. So here's a person with normal hearing in both ears. This is what a person with an acoustic neuroma might have, and this is where the right ear has a much more significant hearing loss. And usually once you're over 50 decibels, we start to say that hearing is really becoming a little bit less useful to you. And so probably just as importantly is your ability to understand words. So we look at the ability to hear a tone, but also to discern words. Vestibular schwannomas have the unique capacity to make your ability to understand words more difficult. They can tend to make voices sound garbled or like Charlie Brown, that sort of thing. And so sometimes even if you can turn up the volume enough, it just amplifies this garble. And so it's a unique feature of these tumors. So it's not just that a hearing aid always solves the problem for everybody. Dr. Deep, I don't know if you want to talk about hearing classification and.
Sure. So as Dr. Carlson alluded to, almost as important, if not more important than just hearing the threshold is actually the word understanding. And I always liken this to, if you think about the old FM radios, if you're right on the correct frequency of a station, you hear it clearly. But if as you're tuning it and you're between stations, it's staticky, well, you're not hearing that clearly. And if you turn up the volume, well, you're just hearing loud or static. And so it's really the speech clarity that we're interested in. That's what creates useful functional hearing. And so one of the measures that we use for this is the word understanding or the word recognition score. Shown here is the table of how we classify this, A, B, C, and D, A being the best and D being the worst type of hearing. And broadly, I like to think of it as basically the 50-50 rule. So when patients have greater than 50 decibels of hearing loss, meaning their thresholds are low, they have a lot of hearing loss, and their speech understanding or their word recognition is lower than 50%, it's less or non-useful hearing, sort of outside the limits of what a hearing aid is going to produce. So highlighted here in green are patients where a hearing aid would still be beneficial. Their word understanding is greater than 50, whereas in C and D, the word understanding is, or in C, it's lower than 50. And in D, the amount of hearing loss is so great that the hearing aid will have trouble overcoming just that loss in terms of it's outside its limits of power.
We had talked about the the prevalence of hearing loss, of one-sided hearing loss, most people who are diagnosed with the vestibular schwannoma present with hearing loss, either sudden or more commonly progressive hearing loss. And if you follow everybody through their diagnosis and treatment of a vestibular schwannoma, we always, if you read about the literature, it's hearing preservation treatments are always highlighted as, like one of the most important things. But if you really think about everybody who comes through with the vestibular schwannoma, about half of people don't have useful hearing at diagnosis, and treatments don't make hearing better. So that group is not eligible for a hearing preservation treatment. And then the other factor is if the tumor is larger, it's not as eligible for a hearing preservation treatment. So even though it's something we talk about all the time, it really only applies to a smaller number of people who are eligible for it. And the truth is, a lot of times the tumor decides up front whether or not you're going to ultimately have good hearing in that ear. If it's a very large tumor, or if you've already had significant degradation of your hearing, there's not a good way or a reliable way to improve your hearing, at least your natural acoustic hearing. And this just shows that most people present with hearing loss. What's interesting is even if you don't treat your tumor, your hearing is likely to continue to decline over time. This is a graph that we like to use in medicine very frequently. It basically looks at if you follow somebody out long enough, what the likelihood of them to keep some function is. And so you can see at time 0, if we took everybody who had good hearing and we follow them out to year 5, only about 60% of people still have useful hearing. You follow them out to year 10, only about 40% of people have useful hearing. So these are patients with vestibular schwannomas who didn't have treatment and their tumor wasn't growing. So that's a pretty important thing. Even if your tumor doesn't grow, it's expected that slowly over time, and maybe in about 15 to 20% of cases, you can even have a sudden deterioration in your hearing. I think that's also an important thing to just mention, that you cannot use your symptoms as a barometer for tumor growth. Some people will call us in the middle of their surveillance schedule, say they're supposed to get their MRI next year, but they developed a sudden hearing loss, and they're really afraid that their tumor doubled in size or it bled into itself or something like that. And the reality is it probably hasn't changed in size. The other thing to mention is your symptoms could be the same and your tumor could even be growing. So just to say that they're not really strongly correlated, and that the most important thing is just to get those serial, meaning over time, audiograms, hearing tests, and MRIs, regardless of the symptoms that you have. This just shows that, again, if you follow people long enough, most people with the vestibular schwannoma end up developing one-sided hearing loss with the other ear still hearing well, regardless of the treatment type you had. And it's only a small number of people that retain useful hearing. People that present with smaller tumors and very good hearing are more likely to retain them long-term. This just shows the difference between the types of hearing loss between a person without a vestibular schwannoma that has hearing loss. So without a tumor, you typically get a high frequency hearing loss, but still pretty good preservation of word function, ability to understand words. Whereas a person with a vestibular schwannoma typically gets hearing loss more in one ear, and the ability to understand words or discern words is poorer. Maybe Dr. Deep, if you want to talk about the deficits people experience when they have more significant hearing loss just in one ear, or single-sided deafness, so to speak.
So single-sided deafness can result in a whole host of different side effects. Probably one of the most, right when it happens, if you have a sudden hearing loss, or let's say you have surgery and you sort of wake up with worsening hearing, it can just be disorienting. Hearing speech in a noisy environment can be obtrusive, disturbing. It's hard to hear. The brain really requires both ears getting signals to really understand speech in a noisy environment. And so that can be a challenge for patients, and it takes some time to adapt to it. Sound localization, the ability to see or understand where the sound is coming from, is also obviously going to be impaired. Everything is going to be coming in from your good ear. And this can serve as a safety issue, such as if you're crossing the street, knowing which side the cars are coming or the horns are honking from, or it can just be more of a nuisance. If you're in front of a fleet of elevators in front of you and behind you, and which one dings, it can just be more of a nuisance in that way. And sometimes patients just have, it's the auditory version of a blind spot. They just don't even hear when someone's speaking to their bad ear. And so we'll talk later about some of the rehab options that just help bring sound awareness to that deafened side. There's also more and more research on cognitive fatigue. If you only have one ear doing all the work, it requires more brain power to sort of listen in and focus on what that person is saying, and that can be fatiguing. And so we certainly see this in some of the even kids or young adults who shouldn't be fatigued by midday. They just need to take a nap when they come home from school, for example. Tinnitus, again, we'll talk more about, is a symptom of the hearing loss. And so whenever you have hearing loss, many of these patients will have tinnitus as well. And this is a brain phenomenon, and I'm sure we'll talk more about that. That is coming in place of due to the hearing loss itself.
There's a lot of causes of hearing loss for patients with vestibular schwannomas. Most commonly, the tumor is causing the hearing loss. The tumor develops from the hearing imbalanced nerve, and so naturally just having a tumor pushing on it can cause some degree of hearing loss. We actually don't know for sure exactly what causes it. There's some different ways the tumor might impact and hurt that nerve or stretch it or cause compression of the blood vessels that grow into the inner ear, or even release some toxins that go into the inner ear. Radiation also has some impact on hearing. Typically, we think that if you have good hearing and you get radiation, your hearing will go away a little faster than if you didn't have radiation, but it's usually not sudden. So if you follow a person who would get radiation, their hearing will go down a little bit faster compared to a person who didn't get radiation. And the radiation has, even though it's a low dose, it does affect the cochlear nerve, and probably just as importantly, it affects the inner ear and the hair cells. And then with radiation, typically your hearing loss is more gradual. With surgery, typically you have surgery and you wake up with retained hearing, or you lose it at that time. So the risk with surgery typically is mostly upfront. During surgery, there's a couple of different ways you might lose your hearing. If your hearing is bad to begin with, sometimes we use an approach where intentionally the inner ear is gone through. It's called the translab approach, and that will take any remaining hearing away. Even if it's already poor, it would take the rest of it away. If we're trying to save your hearing either through a retrosigmoid approach or a middle fossa approach, the goal is to leave the cochlear nerve alone, so don't cause any trauma to it, but also we have to preserve the blood vessels. The inner ear is fragile in the sense it only has one strong blood vessel going to it. It's called the labyrinthine artery. It's a branch off of an artery that's around the tumor, and so sometimes that nerve can go into spasm, and even if the cochlear nerve is preserved, you can lose hearing. Those are the most common mechanisms you might lose hearing with surgery. But again, usually with surgery, it's a little bit of an upfront gamble. If you retain hearing after surgery, we think you're more likely to retain it longer term. Although I will admit there is some controversy even surrounding that particular aspect. This just talks about some of the mechanisms where you could even lose. A lot of people say, well, why would I lose hearing if my tumor wasn't growing? Wouldn't it just stay the same? And a lot of people also ask, if you remove the tumor, shouldn't my hearing go back to normal because you've taken pressure off of that nerve? There are some functions in the body that improve after you remove a tumor, and that nerve, it doesn't have as much pressure on it. And even around the vestibular schwannoma, there are some nerves that do that. So motor nerves usually do that. So nerves that move things. So if you have a little bit of weakness before your surgery and it was kind of a sudden onset, sometimes that improves after surgery to normal. If you have pain on we call it your fifth nerve, that can improve. So a lot of these symptoms can improve, but hearing typically does not improve. If your hearing is poor before a treatment does not improve your hearing on that side, radiation or surgery. And it's probably because there's a lot of different ways the tumor affects hearing. It can grow into the inner ear. It can secrete some proteins, or it can compress the nerve itself or the blood supply. So when we think about treatment, not treatment of the tumor, but treatment of hearing, there are some questions that are really kind of provide us forks in the road to decide which paths we go down. The first question we usually say is, how good is hearing in the non-tumor ear? So a person that has really good hearing in the other ear and hearing loss in the tumor ear, a lot of those people will decide to do nothing because they compensate sufficiently. It's not normal, but they say, well, I'd rather have both ears, but I do pretty good, particularly in a quiet environment. Secondly, we say, is the hearing loss impacting them impacting their daily life? Some people say, I work in a very quiet environment and I do okay. And other people are very reliant on binaural or both ears hearing, particularly people who work in noisy environments, or if you're like a field officer, a police officer, or something like that, or military, you need to have that sound directionality. we often ask people what symptoms are most troublesome to them with regard to their hearing loss. Is it the difficulty understanding people when there's background noise? Is it sound localization? Is it tinnitus? What's bothering them most? And then the main question for treating the ear that has the tumor, the question is the hearing good enough that they can just hear with nothing, or do they need a hearing aid, or is it beyond that, what that 50-50 mark that Dr. Deep talked about, where the hearing aid probably doesn't help as much anymore? Dr. Deep, do you want to talk about hearing aids just a little bit?
Sure. So let's say you're undergoing the observation paradigm and your hearing is slowly declining, but you're still above that 50-50 mark, meaning your word understanding is greater than 50 and the threshold is less than 50, meaning it's better hearing. Well, a conventional hearing aid, just amplifying what hearing loss you have, is going to be our best solution. That's providing the ear that has hearing loss. It's trying to improve it back to quote unquote normal hearing. But the challenge is, as you continue to lose hearing, we get outside the limits of what these hearing aids can do, either because they're not powerful enough or because the speech clarity isn't good. Meaning, again, you're between radio stations on the FM radio, and now turning up the volume just provides louder static. It's just not going to be helpful hearing. And in fact, it can actually worsen your overall hearing. So we like to think about patients with a word understanding. This says greater than 60, greater than 50 or 60 is usually a good candidate for where they can still benefit from a conventional hearing aid. So again, these are patients that are either undergoing an observation paradigm or radiation. Again, hearing loss might continue to decline over the first 5 to 10 years after radiation, and they still may benefit from a hearing aid during that time, while the word understanding is still greater than 50 or 60%. And also, let's say you undergo a hearing preservation microsurgery, and it's not total hearing loss, but there's some hearing loss, or even the effects of age. And these are all patients that may benefit from a conventional hearing aid. I think we covered most of this, but again, one of the things I didn't talk about is that it can reduce the symptoms of tinnitus. So again, tinnitus is a brain phenomenon. It's produced by the brain in the presence of hearing loss. It's the brain trying to give itself the hearing that it's missing. And so if you're amplifying that ear with the hearing loss with the hearing aid, you're sort of satisfying the brain, and the tinnitus itself can decline. There are issues with hearing aids, though. Many of them are not covered by insurance, and they can be very costly. They require maintenance, and there's technology upgrades, and things break down. And so every 5 to 7 years, you're having to replace them. There's also issues with feedback and the occlusion effects that the audiologists have to sort of work with. So it's not a perfect solution, but again, it's our best solution for those patients with some hearing loss. Now, patients that are below that 50-50 mark, particularly, it applies most to patients after microsurgery. Many patients don't even have any hearing in that ear after surgery, or even in patients with just naturally have lost their hearing due to the tumor itself. There's no role for amplification at all. And in these patients, we talk about a few different options. The first being the cross hearing aid. So there's a few different options that reroute sound from your bad ear to your good ear. So this is not restoring sound localization. The good ear is still the workhorse of the hearing, and it's doing all the hearing, but it's preventing the issue that we talked about before, which is the blind spot, the missing the sound. When someone's talking to your bad ear, you're still able to have sound awareness on that side. It's just rerouting it via Bluetooth technology over to the good ear. And so that's being shown here. And on the right side, it says bicross. And in patients with age-related hearing loss in their good ear, not only is it able to receive the information from the poor ear, but it's also amplifying that information as well. And so this is a great solution for those patients that are completely deaf in their tumor ear, and have some age-related hearing loss in their good ear. So this is a nice option for those patients. You want to talk about the Baja, Dr. Carlson?
Yeah, so broadly, we talked about this a little bit, but broadly your options are do nothing in the ear with hearing loss if you have good hearing on the other side. If there's still some good hearing but not good enough, you can put a hearing aid in that side. If the hearing gets pretty bad and you want to do something about it, you can try to route sound to the other side. And that's what Dr. Deep just talked about, the cross aid, which is just purely routing sound to the other side. And the bicross aid is routing sound to the other side and also amplifying it in your other ear. There's surgical ways to route sound to the other side. Most commonly, we've talked about the Baja, bone-anchored hearing aid, and this requires a small screw to be placed through the skin into the bone of the skull, and it will actually vibrate the skull, not in a way you can feel, but enough vibration that the other ear can pick it up. If you recall earlier, we talked about the inner ear having that fluid that vibrates and moves. So if you can throw that vibration to the other side through the bone, then you can actually hear on the other side. This does not restore sound localization. To understand where sound is coming from, you need to be able to hear with both ears. This throws sound to the other sides. So this will help you if you're walking down the street, there's a little bit of background noise and someone's talking quietly into your deaf ear. It'll throw sound to the other side. You'll hear it pretty well on your other side, but it won't give you that sound localization back. Bajas, or bone-anchored hearing aids, use this, what we call a percutaneous screw. So that means there's a little screw that's coming out through the skin. Maybe about 5 to 20% of people can get skin irritation around this screw. We call it overgrowth. It almost looks like an infection sometimes. And so there are some downsides to it. Some people don't like the appearance of it, although a lot of people will hide it under their hair if they have hair or longer hair. But nonetheless, some people don't like it for that reason. Because of that, there was this device that was called the Attract system. And that system works through, the next ones I'm going to talk about all do the same thing. They route sound to the other side, but they use different systems to do it. So the percutaneous means it's coming through the skin. The transcutaneous means that it's using a magnet or something else to connect, but it's not physically connecting. So there's no screw coming through the skin or something else. There was a system called the Attract, the Baja Attract, and it used a very strong magnet underneath the skin on the outside. It would kind of pinch the skin in between, and that pinching of the skin would allow you to get vibrations through. But the problem is the magnet had to be pretty strong, and so a lot of people had some degree of pain from it, and so a lot of people didn't do that procedure or didn't like that procedure. But more recently, in the last, I'd say, year and a half in the United States, 2 additional options became available where it doesn't cause as much pinching, but it does allow you to have a device underneath the skin so you don't have this thing coming through. One is called the Cochlea Implants, and the other is called the Med-El Bone Bridge. Both of those systems have an external processor. It's circular, it's about that big, and it's relatively thin, and it will stick through a magnet. So there's nothing coming through the skin that you have to connect to. And that contains a battery and a microphone, and then it works through RF, so radio frequency induction loop. So it sends it through the skin through radio waves, and then the internal device will pick it up, and then it will vibrate the bone on the inside. And the device on the inside actually has what we call the driver. So it vibrates the bone on the inside, and then it can route it to the other side. All these things, Baja, Ossia, Bone Bridge, all of these require a surgery. The surgery is relatively short and very low risk, but it does require surgery nonetheless, which there's pros and cons. One of the biggest pros a lot of patients see is that it's usually covered by insurance, whereas hearing aids usually are not. Really, feedback is not a major issue, at least with the ones that are underneath the skin, because your microphone and what you're amplifying is actually bone vibration, so it doesn't have that as much of an issue. And typically, you can upgrade your external processor, but you don't have to get something new every 5 to 7 years that you're paying for, that sort of thing. So there are some advantages to it. If you're interested in seeing videos on all of these different technologies and how they're implanted, we actually have a YouTube videos. Some people don't like to see any blood, but if some people want to know what's going on in the kitchen, So if you want to see it, there's a Mayo YouTube channel. So for example, if you searched Mayo Clinic and Bone Bridge, it should come up that way, or Mayo Clinic and the Ossia, OSIA, or Mayo Clinic Cochlear Implant or something like that. You'd see surgical videos that we've made that really give you details about what we're doing through the whole procedure, and it walks you through it. So some people like it, some people don't, but something you can look at if you'd like. These just talk about the different systems. Again, we talked about percutaneous, meaning going through the skin, and transcutaneous, meaning coupling through the skin, but not actually something physically coming through it. This is what, you know, these systems help you with. But so if you're walking down the street, so not most things in life don't give you only good things. There's often side effects or things that aren't as good about something too. There's, you know, you take the good with the bad and you decide if that balance is good for you. Same thing is true with these cross systems, routing of signal systems. If you're walking down the street and someone's talking into your deaf ear, and there's a little bit of background noise, this system will help you a lot. It'll throw it to your good ear. But there is a situation where if you're walking down the street and there's a lot of background noise and they're talking into your good ear, but you're routing bad sound into your good ear at the same time, it's actually a negative thing. So it's not like these things are perfect, where you just get a cross aid and you're back online. It's like nothing ever happened. There are some situations where people don't like a cross system. And so, you know, by and large, I would say that even though 80 or 90% of people with vestibular schwannomas have one-sided hearing loss, it's very significant. We did a study on it. Only about 10 to 20% of people actually use a system to try to route sound or something like that. It's just probably because the technology doesn't really solve all the problems. It helps with it, but it doesn't solve all the problems. And it's also something you just have to, you know, deal with. You have to charge it, those sorts of things. So these systems that route sound to the other side, whether through hearing aid systems or, you know, the Baja Ossia bone bridge, they might enhance speech understanding when there's background noise. And they usually are covered by insurance, but they don't give you hearing in both ears back, so you can't localize sound. And there are some specific issues pertaining to each individual device. Dr. Deep, would you be interested in talking about cochlear implants, and particularly as it pertains to vestibular schwannoma?
Definitely. So in patients, in a very select group of patients with vestibular schwannoma, there may be a role for cochlear implantation. Generally, cochlear implants it's an implantable, surgically implanted device, as shown here, that goes into the inner ear, which is that it's electrically stimulating the nerve of hearing, and that nerve of hearing is then going to the brain, where that you then actually hear sound. It requires, unlike a hearing aid, the cochlear implant does require, you know, at least 3 to 6 months to adapt for your brain to learn how to make sense of this electrical sound. But in the vast majority of patients, they're able to understand and regain functional, useful hearing. In addition to, you know, many patients, up to 80%, getting some benefit of tinnitus suppression. So cochlear implants have been really a game changer for certainly kids who are born deaf. We're able to really change the trajectory of their life. And in addition, patients with age-related hearing loss. Now, when it comes to patients with vestibular schwannoma, there are a few criteria that makes a patient an implant candidate or not. The first is, do they have a cochlea that's accessible? And by and large, most patients with vestibular schwannoma, that is the case. That's not the problem. The bigger issue in patients with vestibular schwannoma is, do they have a cochlear nerve? Many patients, certainly those with the medium to large size tumors that undergo a surgical resection, the cochlear nerve is often very hard to save, and it's not there at the end of surgery. In surgery, our focus is on removing the tumor and saving the facial nerve. Now, some of that is changing as we think more about cochlear implantation. If we're thinking about that ahead of time, it could change how we approach microsurgery in terms of facial as well as cochlear nerve preservation. But historically, the cochlear nerve has not really been something that we're thinking about saving. This is just a picture of the external device right here that communicates through magnet to the internal device. And this is a picture of the cochlear implant itself. So now patients that have undergone radiation, there is still a cable connecting that cochlea with the brain, and so there is a good chance that stimulating that nerve will transmit a signal to the brain. And it's somewhat counterintuitive, but despite having a tumor in proximity and compressing the cochlear nerve, this cochlear nerve is still typically able to transmit that signal. It can be degraded and somewhat garbled, and so in some cases the outcomes that we get with cochlear implantation in patients with an acoustic neuroma aren't as good as conventional cochlear implant candidates, but it's certainly better than nothing in a lot of cases. And again, a lot of the times it depends on what they're doing it for. Are they doing it for the tinnitus suppression? Are they doing it to regain hearing, to restore sound localization? Depending on the size of the tumor, how it's been treated, with whether radiation, observation, or surgery, and just the status of the cochlear nerve, a lot of that depends. And there's growing literature with experience in patients with vestibular schwannomas undergoing cochlear implantation. And again, by and large, they are a great benefit, but again, it depends on the individual patients and their motivation for getting it. And again, very few patients actually meet this criteria in the first place.
This just shows a schematic of what a cochlear implant surgery is. Again, all of this is online on the Mayo Clinic YouTube channel, including actual surgery for implantation in adults. I think probably, given our current time, it might be good to open up to questions. I think we've covered the main different treatment options. We could go into some of the outcomes, but maybe just in the interest of time, we could go into questions.
Okay, that's great. Thank you so much, Dr. Carlson and Dr. Deep. That was very informative. We do have a couple questions today. We have some here in the webinar and then on Facebook as well. So the one that's here in the webinar is about audiograms and how often they're recommended post-treatment after radiation. So and also how frequently should an MRI be done, and should those two be done simultaneously or coordinated in some way?
That's a great question. I just want to put in a shameless plug. Over the last year and a half, we worked with a group of 16 different neurosurgeons and otolaryngologists to develop what we would consider some general guidelines for following tumors with MRI, the frequency of following a tumor, frequency of scans, frequency of audiograms, and things like that. It was developed through what we call a Delphi consensus method, where everybody works to vote on different aspects and provide their input on it, and then working through the process kind of systematically, we'd say, you can probably arrive at better advice than what you might get just from one person individually. So that is available online at Otology Neurotology, and there will be a follow-up newsletter coming through the ANA shortly on that piece. So if you're interested in it, I think there were a total of 103 different statements that talk about different aspects. It's important to say that those guidelines are just that, they're guidelines and they're not standard of care. Every patient is individual, and what you might need is more specific to your exact situation. But in general, there's kind of two reasons to get a hearing test after treatment. The most important is, how is the patient doing? But also, we also like it to understand what the outcomes are, so we can study them, so we can also tell future patients what they might expect. So in general, with radiation, you get an audiogram beforehand, and then it's good to get one probably yearly, and certainly at least every other year. A lot of people, so that just allows us to follow it. If you develop non-useful hearing in that ear, a lot of patients will say, well, I don't need more audiograms, and it's a waste of my time because I know my hearing's not good. And we understand that, and we're definitely sympathetic to that. That's reasonable, but sometimes we still even continue to follow it, even if you get past that non-useful hearing, because it does help us benchmark what radiation does to hearing, and it helps us understand it better so we can counsel people better long-term. The frequency of radiation, frequency of MRIs after radiation is different at each individual center, but because the tumor's not being fully removed and it's still there, it's typically more frequent than what you would do if you had surgery. Mm-hmm. We usually get one at the 1 year mark. Some people will get it at the 6 month mark, and then you usually get it yearly for several years. Then you go to every other year, and you keep spacing it out the further you get. But the recommendations for the frequency of your scan are somewhat different between individual centers. It's a good question. Again, if you want to see that guideline, I encourage you to look at our online paper.
Okay. We've had several questions about tinnitus and wanting to know if any one of these types of hearing aids is better in helping with that or not. And then also, maybe a little more explanation on what, why it happens and why it seems to be exacerbated by stress or being tired, why it gets louder. And then last but not least, why a hearing aid might help kind of diminish tinnitus, but not help with increased sound, like not necessarily hearing better. It's a lot of questions, sorry.
So as I mentioned earlier, so tinnitus is not coming from the ear, it's coming from the brain. It's a brain phenomenon. You've probably heard of phantom limb syndrome when a soldier comes back from war and let's say they've lost their arm, but they have this sort of phantom sensory sensation that their arm is still there and they can feel it or they want to itch it. It's a brain phenomenon. The brain feels like there should be an arm there, and so it's giving you the sensation of that. Well, the same thing is happening with tinnitus. The brain is used to getting hearing from this ear with the tumor, and now it's not, and it misses it, and in the absence of hearing, it's putting in this phantom phenomenon called tinnitus, this ringing, and unfortunately, it can be very bothersome. So that's why it happens, and that's why you can't put an earplug in the ear to stop it. It's coming from the brain. There's no quick fixes. There's no pills that have been shown to do anything for this. How do we treat it? Well, we treat it by restoring sound to that ear. Now, again, most of the damage done by an acoustic aroma or its treatments cannot restore hearing. If you're in the observation group or radiosurgery group and you still have some usable hearing that can be aided, meaning you can use a conventional hearing aid to amplify that sound, well then you're giving the brain more of the hearing that it's missing, and so that tinnitus can get better, can get diminished, if not totally gone. The crossover devices, the Baja, the cross hearing aids, are not going to suppress tinnitus because you're not bringing any sound to that ear. A cochlear implant, if you're in the small group of patients after surgery that still have a cochlear nerve, whereby a cochlear implant can be of benefit, or if you've undergone radiosurgery and the tumor is stable and now you're just dealing with a hearing loss, you can undergo a cochlear implant and that can restore hearing in that ear. And in about 80% of patients, they'll get tinnitus suppression or it completely goes away when the device is on. Now, when you take the device off to go to sleep, it typically comes back. But for the most part, it's suppressed when the device is on. And again, it's because you're giving the brain the hearing in that ear that it's otherwise missing. Did that cover most of those questions, Melissa?
I think so. Yes, that's great. Thank you so much. We had a question about the effectiveness of bone conduction headphones and things like the Aftershock, I guess, or Bose and similar products. Is that something that is helpful for vestibular schwannoma patients?
So we had talked about it earlier, but there's kind of three types of hearing loss you can have. One is where you lose, there's some mechanical blockage, and that could be from fluid or infection or eardrum tear or rupture or one of the bones of hearing being gone or something like that, or even trauma. And then the other type is nerve hearing loss, and you can have what we call a mixed. So it's a combination of both of those. Bone conduction devices can be used in two different contexts. One is to put sound back into the ear that has a mechanical blockage. And so like if you're missing the bones of hearing in your right side because of surgery or whatever else, you can put a bone conduction device on this side and actually put sound back into that ear. Pretty effectively, very effective. Some people are born without ear canals, and we use it all the time for that. It's very good. That restores hearing in both ears. People with vestibular schwannomas don't have conductive hearing loss. They don't have mixed hearing loss. They have sensory neural hearing loss. That's different. So any bone conduction system you're using, if you have a vestibular schwannoma, is to throw sound to the other side. Tight headband or those different systems that cause do bone conduction through one of those devices. There's all these other ones that have existed too. Like, for example, there was one called the sound bite that worked off a retainer in the jaw, like in your mouth off your tooth. There's all these different systems. They'll throw sound to the other side, but they don't restore hearing in both ears. It just continues to run it to the other side. So you don't localize sound. The difference between like a tight headband or a headpiece or headphones that use bone conduction and one of these surgically implanted devices is the surgically implanted devices provide more power usually. When you have a device that just pushes on the skin, there's what we call attenuation through the skin. You lose some of the energy, but it vibrates through anything soft. And so to transmit to the other side, it might not be as powerful, which in some people might not be a big deal if the other ear is really good. But if you have any degree of hearing loss on the other side, you can't really effectively route sound to the other side. The other thing is you have to obviously be wearing it for it to work. And sometimes some of those have to be kind of tight to get the transmission that you need. Most people, if you're routing sound to the other side, most people will either use cross by cross, so like a non-surgical hearing aid or a surgically implanted one. And very rarely would you use like the Adhere, which is a sticky bone conduction device, or a sound bite, which is no longer available, or a tight headband or a Bose bone conduction. You could, but it's just probably not the best long-term solution for it.
Gotcha. Okay. And so there's lots of reasons why we hear from vestibular schwannoma patients why they might choose not to get a hearing aid, whether it's too expensive, it's not covered by insurance, they're adjusting, they feel like they're adjusting, but there still is that loss and they struggle with it. So for patients who choose not to or are not able to get a hearing aid, do you have strategies or techniques that you counsel patients that they can use to kind of help adapt to the hearing loss on the single side?
I think that's a great question. I don't typically engage the discussion of hearing loss rehabilitation until about 3 months after surgery, because many patients do adjust. It takes about 3 to 6 months for your brain to adjust to this new normal. And it's really hard at first. Like I said, it's very disorienting when you go to a loud room. And just psychologically, it can be very stressful. For those patients that don't or can't, for whatever reason, get a cross hearing aid or one of these devices we've talked about and just want to adapt, I think one of the biggest things is just setting the expectations. And that's whether it's with your partners or the people, your coworkers, having them understand that you can't hear out of this ear. And if they're going to talk with you, it needs to be face to face or acknowledge that they should be standing on the correct side. Just as long as everyone is aware of this, it can reduce some of the frustration. And so I think that's probably one of the biggest things is just raising awareness to the people that you work with and your loved ones. And so they can, and I think by and large, people are sympathetic to that and they'll work with you.
Okay. We've talked about patients for the most, and you addressed this at the very beginning, Dr. Carlson, that the of this talk would be about patients who had hearing loss on one side, but there are patients who have an acoustic neuroma on one side, and that tends to be their hearing ear. They have hearing loss for whatever reason on the other side. We have a patient that asked a question about and said they actually had acoustic neuroma surgery, had fine hearing, got lost the hearing in the acoustic neuroma ear, and then eventually later got a Baja, and eventually later started having hearing loss in the hearing ear and ended up with a regular hearing aid in that ear. She was wondering if that had anything to do with the acoustic neuroma, but then also how do you handle hearing rehabilitation in patients whose hearing ear is the acoustic neuroma ear and there's complete loss on the other side?
It's interesting. So one main question that you posed is, does a vestibular schwannoma on one side cause hearing loss in the other ear? We don't think so. We don't think it secretes any significant protein to the opposite ear or any sort of toxin in the CSF space or something like that. There are, if you have enough people in the world with a particular condition, you'll always have you'll have some unusual stories sometimes if you have enough people. And like, I'd say at least a couple times a year, we see a person who is diagnosed with the vestibular schwannoma incidentally. So they might have a sudden hearing loss in their right ear, and you get a scan and their tumor's on the left side. And that's you'd say, well, the chances of getting a sudden hearing loss are really low and the chances of getting a vestibular schwannoma are really low. So they have to be related. But the reality is there's enough people in the world with this that you can coincidentally have a couple strange things happen. So out of the 200 people we see new people a year with this, we might see 1 or 2 people with that sort of situation. So by and large, we don't think a tumor on one side causes hearing loss the other. You do want to make sure you don't have NF2, which is would be very uncommon to misdiagnose it, but you could have a tumor on both sides, or even in the inner ear, which is harder to see. We call them inner ear schwannomas or intralabyrinthine schwannomas, et cetera. But most commonly, that sort of situation is coincidental. There also are very, very rare times where you might have surgery on one side and develop a contralateral hearing loss. That has been reported. It's uncommon, but it can happen either immediately or in a delayed fashion. It's probably related to some sort of inflammation in the meninges, not necessarily meningitis, but some sort of post-operative inflammation or something like that, or a low CSF pressure for temporarily during surgery that might have some impact on the other ear. That's a very, very rare event. Some people are born with hearing loss in one ear, and then later in life, they develop a vestibular schwannoma in their other ear. Or some people, there's all these different situations that we've encountered over time where it's honestly a little bit of bad luck that you develop hearing loss in the non-tumor ear as well. The ear that doesn't have a tumor can be managed a little bit easier than the ear with the tumor because the cochlear nerve's not at risk. So that broadly, if you just talk about somebody without a tumor, you talk about hearing rehabilitation, you start with doing nothing. If the hearing loss gets significant enough where it's impacting daily life, we give a hearing aid. A hearing aid will rehabilitate hearing loss up to about 50 or 60% and 50 or 60 decibel levels, as Dr. Deep talked about. And when you go beyond that, then you're a candidate for a cochlear implant often. And particularly for a non-vestibular schwannoma ear, cochlear implants typically do very well. It's not normal, but it's quite good for most people. The other option is what we talked about earlier. You can do the bicross system. So you could, if you're deaf in one ear, the vestibular schwannoma ear, or close to deaf, and your other ear has some hearing loss, but still pretty good, you can pipe sound into the other side through the cross system. But then on your other side that has hearing, you can amplify it too. So you can route sound and amplify that routed sound to help an ear that has some degree of hearing loss, but that's not deaf. So a lot of different options. But again, what we went back to is most people adjust to the one-sided hearing loss. And if you take all patients in the world with one-sided vestibular schwannoma, at their end of their journey, over 80% are going to develop non-useful hearing in the affected ear, either from the tumor itself or from treatment. And only about 10 or 20% of those people that have that hearing loss actually go on to really pursue a hearing treatment. That's a reflection of two things. Most people adjust pretty well, and also the technologies are not perfect. Mm-hmm. If there was a perfect fix, everybody would do it, but each has their benefits and drawbacks.
Sure. Okay, well, we are going to wrap up this presentation. Thank you both for talking to us about hearing rehabilitation. We